Hi, Fortune.
Hi, Dr. Bennett.
How you doing?
I'm fine, and you?
Good, good. Your camera's not on there, so you gotta adjust it a little bit.
Okay.
Right. You see at the bottom left of your screen is a picture of, it says mute and stop camera, right?
Okay.
go to the camera setting. There's a menu there. Open it up, and you got to pick a camera.
Okay. Mm.
Can you find it?
No, not yet.
Oh, okay. Okay, at the very bottom of your screen at the left, you see the mute button? It says mute and stop video. You see that?
Okay, new video, not yet. Let me check.
You see the mute and the stop video? You need to go to the video menu. There's a menu next to the camera.
Okay.
Do you see that?
No, I don't see it.
Oh, you don't say, what do you have, an Apple or?
Apple.
Windows?
Apple.
Oh, okay, Apple's, the menu may be different. You need to find the video settings.
Okay.
Do you have a picture of a video camera and a mute button on your Apple at the bottom or the side or whatever?
Let me check.
And should have participants, Q&A, polls, share. You see the share button?
No.
The bottom of this, well, I don't know where it is on Apple.
Let me see.
How to screen share. Do you know how to screen share, Fortune?
Yes, I
Okay, show me. Show me how you screen share. Show me. Show me.
Here is my screen share. Okay.
Okay.
Share conversation. I don't see how to show you my screen. I'm sorry.
Oh, it's okay. It's okay. We'll teach you. Okay, let's start with a camera first.
Okay.
Because it'd be okay. You reboot, you're probably connected to something else like Skype. So you need to reboot your computer and come in again. Like turn it off completely.
Okay, okay.
And then come back.
Okay. Okay.
Okay, I see you. I wait here. Hi, Musindo, are you there? Hi, Musindo, are you there? ¿Está allá, Musindo? Maybe not.
Okay, thank you.
Okay, let me see if your camera's on. Is your camera working? Do you use Skype at all?
Yeah.
Do you have problems with the camera?
Yes, I have a camera.
Okay, but you can use the camera on Skype, right?
Yes.
Okay, so we got to figure out how to connect it now.
Okay.
Let me see. Oh, it has here. You have a camera there. You just need to turn it on. Before you didn't have a camera. You just need to turn it on.
Okay.
You need to turn your camera. I can see your camera's hooked up to your computer.
Okay. In setting, I think.
Yeah, you need to find on Apple where how to turn the camera on.
Okay. Okay.
In the Zoom platform, do you see where it says share? Do you have a share screen?
Yes, I find it.
Okay. On that, is there a camera, a picture of a camera? It says stop video.
No.
Okay, you're sharing it now. It looks like
yes,
you're sharing.
I show you now.
You're sharing it now. Okay. Because you can share without having a camera, but that's how you. Okay, open your PowerPoint with that.
Okay.
Open your PowerPoint. Okay, there's your PowerPoint. You see it?
Yes.
Okay, that's what you see. Okay, that's it.
Yeah, I see it.
There you go.
Okay.
Okay, but let's see if we can fix your camera. Okay, so that's how you screen share.
Okay.
Okay, now get off the screen share. Okay, and show me around your show me around your Zoom. Show me around. Okay, keep on that screen. I want to see.
Okay.
See where
this is Zoom.
Where the options are to turn your camera on. It should be in the Zoom platform. You got the Zoom open, right?
This is a Zoom platform. This is a Zoom platform.
Yeah, but it's not. You don't have access to the keyboard. Okay, change line option. Put
okay.
No, you need to. Okay, get off the screen share. Off the screen share. Okay, I'm going to kick you. Let me get you off the screen share.
Okay.
Okay, now, hey, Dr. Cabullo.
Hello, Dr. Bennett. How are you?
Good to see you. This is Fortune. He's presenting. Well, he was here. He disappeared.
Yeah, sure.
I'll introduce you when he comes back. Hey, we're going to televise from Tanzania Monday.
Yeah, I just saw on Facebook you posted that you televise.
Yeah, we're going to televise. We're just trying to fix the audio and the video. It looks like a good conference.
Yeah.
So, yeah, let me just try to get some stuff done here. Excuse me for a minute.
Okay, I think it's good now.
Okay, how you doing? Okay, there you go. Fortune. Okay, your camera's working. It's on.
Yes, right now.
Okay, so you found the switch, right?
Yeah,
How you doing? I'm Dr. John Bennett.
thank you. Okay, good.
I'm going to put I have a background here. Do you know bank hall? Do you know Naru, Fortune?
Yeah.
Oh, that's how he introduced you, right, to this platform?
Okay, I'm Fortuné Gangpe. I'm from.
Yeah, we haven't started yet. We won't start for another 15 minutes, okay?
Okay, all right,
So we have a few minutes here. Let me do some last minute promotion, okay?
good.
Excuse me for a few minutes. Okay, Fortune, you know how to screen share, right?
Okay, yes.
Yeah, okay, that's good. So have you been here before? Have you been to a webcast before?
Sorry?
Have you been to a webcast before?
Yeah,
Oh, okay.
Yeah.
Okay,
Yeah.
so you know how it works, right?
yes, yes.
Yeah, first I introduce you, and then I introduce the panel, and then you do your introduce yourself and do your presentation, and then after we may have some questions or comments,
Yes.
and that's it. So how are things? Are you in Rabat also? Are you in Casablanca or Rabat? Or
No, I'm in Fez.
where?
I am in Fez right now. It's in the north of Morocco.
Oh, okay.
Maybe 3 hours from Casablanca.
Oh, okay. So I was just in Spain. I was I was in Lisbon.
Yeah.
And I came through Morocco.
Yeah. Okay.
The plane stopped at Casablanca and then went to Lisbon.
Okay.
Nice airport. Nice airport.
Yes, nice airport, of course.
Yeah.
Mm.
Hello, Amir. Can you hear me,
Hey,
Amir?
hey, John. Yeah, I can hear you. Hello,
Okay.
John.
Is your camera working today? The camera's not on, Amir. There you go.
Hi.
How you doing?
Hi, John.
Okay, we'll
Good,
introduce everyone. Yeah, this is Fortune. He's the neurosurgeon that's presented. He's from Morocco. And Amir is from Iran. He's a medical student.
Okay.
Hi, everyone.
Nice to meet you.
Nice to meet you, everyone.
Yeah, I sent you I sent you the email of a medical student from Iran. That did you get that email?
Mm,
Yeah, I sent it to Amir, a medical student from Iran. So, which
when?
yeah, communicate with her. Maybe she was interested in neurosurgery.
Yeah.
Okay.
And okay, we'll start in a few minutes. Dr.
Okay.
Kabulo, are you there?
Okay.
Yeah, I was telling Dr. Kabulo, Fortune, we're televising a conference from Tanzania on, let me show you. Okay, we'll talk about that later. Okay, I'm going to share the screen of a conference we're televising on Monday. You see this conference here?
Yeah.
Yeah, we're televising this on Monday.
Okay. Good.
And anybody is welcome to watch it. It's going to be on Neurosurgical TV, the whole conference.
Okay.
Okay, let me show you some of the speakers, the sessions here. Maybe you recognize some of the names. Traumatic brain injury. I don't know if you know some of those names. Some are from Africa, some are from Roger Hartle. He's a very big name in neurotrauma from Cornell. I don't know if there's anyone from Morocco here, but there's Junio from Tanzania. But anyways, it's on the website if you can see it. So, okay, are you ready to start?
Yeah.
Okay, let me stop the share and then introduce you. Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good afternoon. This is Dr. John Bennett televising from Miami Beach, home of Neurosurgical TV studio. we have the fortune today of having Fortune Gankpi, a neurosurgical resident from Morocco. He's going to be presenting on subarachnoid hemorrhage. He'll tell you the exact title. Let's first meet the panelists before we turn it over to Fortune. Hello, Amir.
Hello, everyone. I'm very glad to be here and in this presentation. Nice to everyone.
Okay, welcome. Dr. Gabulo, welcome back.
Thank you so much, Dr. Bennett. Hello, everyone. My name is Kabulo from the Democratic Republic of Congo. I'm currently final year neurosurgery resident at the University of Zimbabwe.
Okay, welcome, Dr. Gabulo. Okay, Fortune, please say a few words about yourself and then go into your presentation, and welcome.
Okay, my name is Fortune Gankwe. I'm from Benin, but I live in Morocco. I'm in the final year of my residency program on neurosurgery here. It's in the city of Fez. Fez in the city of, situated in the northern of Morocco. As I told previously, around 4 hours from Casablanca. Okay. It's with very pleasure that I will be presenting the topic today on the management of acute management of subarachnoid hemorrhage.
Okay.
How can I?
Take your time, there's no hurry.
Okay. Can you see my screen?
Okay, we don't see it yet, not yet. You have to click the share button. You got it on the share, right? Open it up.
Okay.
Click the share button first and then open it up. Yeah, there you got it. Okay, there you go. Okay, perfect.
Okay. Thank you very much. Okay. As I told previously, it's very, very pleasure that I will be presenting this topic. Here is the main building of our hospital, Centre Hospitalier Université AFAN 2. And as I took this image on Google Map to show you the city of Fez. Okay, good. Disclosure, no, I have no conflict of interest to declare here. Okay, this is the different part of my presentation today, including the introduction, etiology, pathophysiology, clinical presentation, initial management, diagnosis, treatment, and the complication, how to diagnose them and to treat them. Okay, subarachnoid hemorrhage. I think there is a mistake here. It's a condition with the presence of blood in the subarachnoid space between the arachnoid and the pia mater. It could be post-traumatic or spontaneous, but the post-traumatic subarachnoid hemorrhage is not my topic here. I don't want to talk about the post-traumatic subarachnoid here, but I will focus my presentation on the spontaneous subarachnoid hemorrhage. So some spontaneous subarachnoid hemorrhage concern 5% of stroke, but I find in a literature an article from Burkina Faso, it's in the western of Africa, where they find 3.3% in that country. Okay. The main cause of subarachnoid hemorrhage is the aneurysm. It represents 75 to 80% of subarachnoid hemorrhage. So the incidence of the subarachnoid hemorrhage is 10 per 100,000 population. And this incidence is very, very different from and vary from countries and authors. For example, in Finland and Japan, in Japan, the incidence is very high, up to 20 per 100,000 population. The peak age of subarachnoid hemorrhage is 55 to 60 years old, and female are more concerned than male. Note that 10 to 15% die before reaching facilities, and some authors consider that subarachnoid hemorrhage is more likely to spring in the autumn, and mortality is very, very high, 30 to 50%. On this picture, you can see the different subarachnoid space, the chiasmatic system, the interpeduncular system, and so on and so forth. So everybody knows that here. What are the causes, the main cause of the subarachnoid hemorrhage? Okay, on this table, which I took from the article of McDonald and the Vivancos, you can see here the different group of etiology of subarachnoid hemorrhage. We have the group of vascular malformation, including cerebral aneurysm, account for 80%, fusiform aneurysm, mycotic aneurysm, the arteriovenous malformation, the group of perimesencephalic and the idiopathic condition, the group of cerebral hemodynamic alteration, the group of vascular disease, including amyloid angiopathy, cervical or cranial artery dissection, fibromuscular dysplasia, vasculitis, and so on and so forth. We have also the group of head trauma, the group of blood dyscrasia, the group of infection, the group of toxic causes, the group of cerebral neoplasia, including gliomas, metastasis, pituitary apoplexy, and hemangioblastomas, and also the group of neurosurgical intervention. I add also here at the right side the main risk factor that we found in the subarachnoid hemorrhage: hypertension, alcohol abuse, tobacco, drug abuse, intensive physical exercise, and diabetes are the risk factors which are modifiable. So this factor is an individual factor, but also we have the factor we cannot modify. For example, family history, the sex and age, the connective tissue disorder, such as polycystic kidney disorder, the Ehlers-Danlos syndrome. Okay, here I want to summarize the main cause of subarachnoid hemorrhage. It could be spontaneous or traumatic, and for the spontaneous subarachnoid hemorrhage, we have aneurysm with non-aneurysm causes and over causes. Okay, what about the pathophysiology of subarachnoid hemorrhage? There are two stages of pathophysiology of subarachnoid hemorrhage. Subarachnoid hemorrhage inject blood into the subarachnoid space, and brain injury from subarachnoid occur in two phases, as I told previously. Okay, there is early brain injury that's shown by the neurological grade of the patient, which is caused by the transient global ischemia and toxic effect of subarachnoid blood. And there is a systemic response to subarachnoid hemorrhage that can affect the organ like the lung, pulmonary edema, the heart, myocardiopathy, and the fluid and electrolyte balance. Patients with subarachnoid hemorrhage present with the sudden onset of headache, the most severe headache of a patient's life. And the patient can precise the exact time when the symptom occurs and what they were doing. So it's the most severe headache, and the other symptoms can occur also, such as nausea, vomiting, neck pain, photophobia, loss of consciousness, and seizure. The neurological examination can reveal the meningismus. It's a nuclear rigidity with positive Kenny sign and Brzezinski sign, coma due to hydrocephalus, increased ICP, intraparenchymal hematoma, seizure, focal cranial nerve deficit, particularly the third nerve, with ptosis and diplopia from aneurysm on the posterior communicating artery, which compress the this cranial nerve. We can also find the ocular hemorrhage in the Terson syndrome. Okay. How to manage? What's the initial management? What we can call the initial management of subarachnoid hemorrhage? Okay, I want to show here what's recommended, and later I will focus on what we do in our setting. All patients should admit in the ICU in urgency. Bed rest with head of bed elevated to 20 degree, 30 degree, low level of light, low level of head stimulation, reduced noses, quiet death, complete death, vessel line. Here, we can consider early aggressive fluid intravenous for patient unstable hemodynamically. Airways and breathing management. Consider here also a intubation for patients who are comatose. Cardiac monitoring, maintain euvolemia, temperature, tension in the nursing care. And also blood should be, we should take blood for lab check, CBC, including platelets, prothrombin time, bleeding time, electrolyte, urea creatinine, and troponin. We should correct the electrolyte disorders, and also begin the medication, including analgesic, antihypertension, modine, anti-epileptic drug, and anti-emetic. After that, you can perform the neurological exam for the patient to reveal the symptom and the neurological grade, such as the Glasgow Coma Scale, meningismus, focal neurological deficit, cranial nerve 3 palsy. And after that, all patients underwent all patients should undergo the CT scan. In our setting, all our patients underwent CT scan, and sometimes they come with the image from another hospital or clinic outside. The goals of CT scan is to confirm diagnosis by showing the high density in the subarachnoid space. It assesses complication. For example, hydrocephalus, it accounts for 21%, and also the infarct, the hematoma, who can complicate the situation. The CT scan also can predict the location of the aneurysm. And here I want to show you an example of a CT scan. Here you can see the hemorrhage in the sylvian fissure and also in the interhemispheric space. Okay, when we perform the CT scan, we should grade the patient according to the fissure grading. Here is on this side, you can see the different grades according to fissure grading. Grade 1 means no system blood. Grade 2, diffuse deposition or thin vertical layer of blood. Grade 3, localized clot or vertical layer, more than 1 millimeter thick. Grade 4, diffuse bleeding with or without intraventricular hemorrhage or parenchymal extension. On this side, I want to show you the different grade system we find in the literature. Hunt and Hess grading system, WFNS grade system, and also PASH grade system. But in our hospital, we just use the WFNS grade system. So grade 1 of WFNS means patient just come with a headache, and the GCS is 15. Grade 2 is the patient with GCS 13 or 14 without major focal deficit such as aphasia or hemiparesis or hemiplegia. Grade 3, grade 4, and grade 5 concern the poor neurologic condition for poor neurologic condition patient with for example, grade 5 patient come with GCS 6 or 3 with or without major the focal deficit. Okay, but sometimes the CT scan is normal. So what can we do to make the diagnosis of subarachnoid hemorrhage when the CT scan is normal? The CT scan is normal, for example, when the CT scan is done after 48 or 72 hours. It concerns 5% of cases, and here the lumbar puncture test is very, very helpful to detect the subarachnoid hemorrhage. But the lumbar puncture test is very helpful when it's done after 4 hours, showing not clotting blood in CSF in second cell tube, and after centrifugation, the aspect was xanthochromic. This is the different aspect of lumbar puncture when we are checking about the subarachnoid hemorrhage. Okay, on this slide, I want to show you the CT angiogram for patients who came in our department of subarachnoid hemorrhage, showing the aneurysm at the terminal ICA, internal carotid artery. Okay, here I want to summarize what we do in our department when the patient comes and we suspect the subarachnoid hemorrhage. In our department, for example, our patients are young. The peak age, the mean age was 52 years old, range from 33 to 75, and female are more concerned in our department. Hypertension was found in 25% of our patients. They come with sudden onset in headache in 95% and was grade WFNS grade 1 or 2 in 80%. All our patients underwent the CT scan and the CT angiogram. When we make the diagnosis on CT scan and the CT angiogram, we perform a catheter angiogram in 90% of our patients, and we decide in the method to treat them, endovascular or surgery. The factor to make the decision depend on many factors. Before going there, I want to show you on this slide the catheter angiogram of women who came just last week in our department. It was a woman, 33 years old. She was grade WFNS grade 1 and Fisher 3. And here you can see on the picture, the double aneurysm on the right posterior communicating artery and also the anterior choroidal artery. Okay. What we do in our department, remember that when I was exposing the initial management about the guideline, I told that all the patients should be admitted in the ICU. Okay, here I just want to make a difference here. In our department, all patients were admitted on short stay in ICU of urgency, which we call déchocage, for the condition of patient, bed resting, vessel and so on and so forth, clinical examination to find the neurological focal deficit, GSS or PPIN. We perform imaging, CT scan and CTA. We grade the patient according to the WFNS grading system. We begin the medication, analgesic, antiemetic, Modins 60 milligram every 4 hours. We give also to patient the anti-epileptic drug, but this is very controversial in literature, but in our department, we'll automatically give it to the patients and also the nursing care. Okay, when the patient was given WFNS 1 or 2, our patient were admitted in the inpatient unit of neurosurgery, not in the ICU. When the patient was in the poor grade, we admit that in the ICU. And also when the patient has WFNS grade 4 or 5, EVD placement is automatically placed done in this condition with ICP monitoring. So it could be very different from other setting, from other hospital or other department. This is very adapting our condition here in FACE. Okay. After that, what's the decision-making process? When we make the diagnosis of subarachnoid hemorrhage, depending on the clinical presentation and also the presence of blood on CT scan and the CT angiogram. The following day, we organize a joint meeting with the interventional neuroradiologist and for the decision-making process for treatment option, coiling or surgery. Okay, I just want to invite you to read these 5 studies. Is that Finnish study, Brat Chinese study, and the 2 meta-analyses conclude the superiority of endovascular treatment. But in that studies, the authors add that rebleeding or non-complete occlusion are high in this option. So what are the different factors of the decision making? It depends on the healthcare environment, equipment available, the skill set and experience of the neurosurgeon interventionalist, the anatomy and location of the aneurysm, the favorable dome or neck ratio. More than 2 is very favorable for coiling versus wide neck aneurysm. MC aneurysm may be difficult to coil because of the branch near the neck. The basilar apex is favorable for coiling, and the associated intraparenchymal hematoma, subdural hematoma, surgery allow both evacuation of hemorrhage and the treatment of aneurysm. I want to show you here the video of surgery for clipping. Okay, you can see on video through the standard pterional approach, the craniotomy was done, and you see here the circular aneurysm. We dissect very carefully. You can see here the chiasma optic, the optic chiasma. Okay, dissection will continue. Okay. We dissect the branch near the neck and the neck of the aneurysm. We put here the esagil clip on the neck of the aneurysm. Okay, good. Okay. What's the timing of surgery or endovascular method to treat the aneurysm? The timing of the aneurysm obliteration by surgical clip placement or coiling remain, I think, controversial in the literature and varies according to the individual institution. But the general consensus for definitive treatment has shifted from the late surgery to early surgery today, based on many results in literature. Early surgery means surgery performed before 4 days, 3 or 4 days. So this is done on this paper, on this article I show you here from Pack and colleagues, and also Philip, our colleague. They found that when we treat the patient very early, this decrease the in-hospital rebleeding and also the vasospasm and lead to better outcomes. I want to show you on this slide the post-operative CT scan after clipping in our department, and also the angiogram after post-clipping on the anterior communicating artery. You can see here arteries, and also the image of the clip. Okay, here I want to show you the coiling of the patient I presented previously on this I don't know. Okay, you remember this this image? It's a woman who came on in our department last week, and we performed the coiling. This is on this picture. It's a time of first coiling here, and the second one you can see the final control showing that artery was aneurysm was coiling maybe very well. This is the CT scan post coiling to the same patient. Okay. What about the complication? There are some complications of subarachnoid hemorrhage. The first one of them is the vasospasm. It's Ecker and Riemenschneider Schneider in 1951 who described who did the first description of the vasospasm from aneurysm subarachnoid hemorrhage. It's the delayed neurological deficit in context of subarachnoid hemorrhage, such as the low of level consciousness, the focal neurological deficits, motor or speech. It's the delayed cerebral ischemic on CT scan, and on the angiography, we found the arterial narrowing demonstrated on cerebral angiography in 50% of subarachnoid hemorrhage. The time course of vasospasm is from 3 to 14 days, never before 3 days, and very, very rarely after 17 days. It concerns 1/3 of patients between 6 and 8 days. It concerns also, the factor is the initial poor neurological condition at admission and high Fisher grade. I want to show you here on the angiogram the image of arterial narrowing here. This is from patient in our department. Okay. How to prevent the vasospasm? There is no effective prophylactic intervention for cerebral vasospasm, but some molecule can be used. For example, nimodipine, 60 milligrams every 4 hours. The initial management of subarachnoids should be done, and also the exclusion of aneurysm, clipping or coiling favor the prevention of the vasospasm. When it occurs, the vasospasm, when the vasospasms occur, we can manage it with the initial management of subarachnoid hemorrhage, exclusion of aneurysm, and the triple H therapy, hypervolemia, hypertension, and hemodilution. But be careful about the rebleeding when the clipping, when there is not the aneurysm was not clipped or coiling. So it's very, very difficult to manage the vasospasm with this triple H therapy when the aneurysm was not clipped or coiling. I want to show you on this slide, on this picture, the vasospasm for the same patient we coiled last week. Vasospasm of the anterior A1, anterior communicating artery here on during the coiling procedure. The second one of the complication is rebleeding. It's the most important cause of early death after aneurysmal subarachnoid hemorrhage. 50% of patients with rebleeding occur within 6 hours from onset subarachnoid hemorrhage. The prevention is to prevent it is just to treat the aneurysm by coiling or clipping. But some authors suggest to use antifibrinolytic drugs such as tranexamic acid, but be careful about a thromboembolic accident and seizure when using these drugs. On this table, which I took from the article from PAC in the collaborator, they show that when the patient, it's an article on the formal, on they build the paper for the research on 2 periods from 2008 to 2011. These patients are treated very, very early before the 24 hours. And the second arm of article is the group B from 2001 to 2004 when the patient is were treated in late delay. So they found that the rates of rebleeding differ from the group A to the group B. For example, in the group A, it was 1.8% of patients who rebleed, and in the group B, it's 6.5 who rebleed. So it's very, very higher in the group B more than the group A. Another complication of subarachnoid hemorrhage is the hydrocephalus. The acute hydrocephalus occurs in 15 to 20% of patients with aneurysmal subarachnoid hemorrhage. The pathophysiology is a very complex multifactor, such as the blockage of CSF circulation or to increase resistance to CSF outflow at the arachnoid granulation. Ventricular drainage is sometimes necessary for life-saving. EVD is associated, but EVD is associated in some article with rebleeding and in need of permanent change. In our setting, we put EVD for patients grade WFNS grade more than 2. And the complication of this procedure are the infection and rebleeding. I want to show you here on this picture an example of the hydrocephalus in condition of subarachnoid hemorrhage. Other complication include seizure, 20% of patients. It was associated with rebleeding, and as I told previously, antiepileptic drugs are not recommended, but in our setting, we automatically use the anti-epileptic drug. Also, another complication is a neurogenic stress cardiomyopathy, the neurogenic pulmonary edema, the electrolyte disturbance, the Salt-Vaccine syndrome, which we should manage in the patient condition. Okay, thank you very much.
Okay, very good. Thank you very much, Fortune. Excellent presentation. Let's open it up for comments from the panel. I'd like to ask a question, but let me see if Dr. Gabulo has anything to ask first. Dr. Gabulo, are you there?
Yes.
Go ahead, Dr. Gabulo.
Thank you. Thank you so much, Dr. Fortuné.
Thank you
for
Welcome.
that great presentation. I have a few comments, then I have also questions.
Okay.
I'm sorry, my internet is not stable today. That's why I'm not putting my video.
Okay.
Okay. So the first comment, it's on Fisher grading.
Yes.
The Fisher grading, the one you showed, it's an old classification. There is now a new one called modified Fisher.
Yes.
Modified Fisher. So the one you showed us, it was the old one. So maybe you can try to see the new one. It is called modified Fisher. Okay. Then I have a couple of questions. Like you said in your center, you give anti-epileptic drugs to all patients with subarachnoid hemorrhage.
Yes.
I want to know which one are you giving and why are you giving anti-epileptic? Do you give to everyone or you only give to patients who are presenting with seizures? I don't know. Do you want me to ask one by one? I ask a question, you answer, or you want me to list all questions, to give you all questions, then you answer?
As you want. I propose to finish your question and after you will answer.
It's okay. So that's one. Then, like in your center, what are the general conditions? How are you keeping the patient with the subarachnoid hemorrhage, like the general non-pharmacological treatment of subarachnoid hemorrhage? And the third question, do you also do DVT prophylaxis, deep vein thrombosis prophylaxis? And if you do it, when do you start that? Then the last question was, you said you put an external ventricular drain on all patients with WFNS grade 2. Is it all patients who present with WFNS grade greater than grade 2, you put EVD? What about if the patient doesn't have hydrocephalus? Do you put EVD, or it's only patient with the WFNS grade greater than 2 with hydrocephalus? So then another comment, that's my what I learned from Professor Vinko Dolenk. I met him two years ago. So he was the first neurosurgeon in the world advocating aneurysm treatment in the acute stage. That was in 1974. Of course, it depends on centers, like in your center, what you showed us. It depends also in our centers, like after the first 3 days, if you don't operate, then you have to wait for after 21 days, then you take the patient. But him, it was like in acute phase. Once the patient present, he was operating those patients. So there's even a story he told us how he started to do that. It wasn't easy for him. His seniors were refusing, but he was in court stubborn, and he managed to save a lot of lives that time. So yeah, so that was my little contribution about the experience of Professor Vinko Dolen. So I hope I think I asked 4 questions. Thank you so much, Dr. Fortuné.
Okay, thank you. Thank you for your comment and question. Yes, you are right about the Fisher grading I showed. It's the Fisher grading system. I know that there are the modifier Fisher grading, but okay. So thank you for the comment about that. Why do we give the anti-epileptic drug to the patient, to our patient? Okay, we give the anti-epileptic drug to all our patients. It's the habitude in our center. I can tell you exactly why but we remark that in our center, the patients who came and they don't have the seizure, when the seizure occurs, they rebleed. So that I'm agree with you, it's very, very controversial in the literature, but in our center, it's the habitude in our center to give anti-epileptic drug to all the patients who come with the subarachnoid hemorrhage. The general condition, yes, our patient, as I show in in my on my slide.
Excuse me, doctor. Move your camera up a little bit. We can see the top of your head. Move your camera, please. Yeah, adjust your camera. We can't see your head. Okay, there you go. There you go. Okay, perfect. Thank you.
Okay, thank you very much. Sorry. Okay. In our center, 80% of our patient was grade WFNS 1 or 2. So that's the condition of our patient. They come with a sudden onset of headache and okay, the 80% of them had WFNS grade 1 or 2. So just 20% of all of them was grade more than was WFNS grade greater 2, greater than 2. Did we begin the deep thrombosis prophylaxis? No, in our setting, in our center, we don't give the deep thrombosis prophylaxis to our patients. Never. What else? The last question is about the EVD placement. Yes, I said that for the patient who came in our center with WFNS greater than 2, we put the EVD placement because we found that all of them has a poor neurologic condition, and to manage the ICP, it's helpful to place the EVD for these patients. So it's not just to manage the hydrocephalus, but it's also to manage the monitoring of the ICP. What else? I think these are the answer I can give to your question.
Did that answer all your questions, Dr. Gabulo?
Thank you so much, Dr. Fortune, for your answers. Yeah, thank you so much for your answers. Like I was saying, for the Fisher grading, the modified one, it's now the grade 1, it's focal or diffuse thin subarachnoid hemorrhage with no intraventricular hemorrhage. And grade 2, it's the same with grade 1, but with intraventricular hemorrhage. Grade 3, it's thick subarachnoid hemorrhage with there's no intraventricular hemorrhage, and for thick subarachnoid hemorrhage, when they are talking about thick, it means greater than 1 millimeter, like you mentioned also.
Yes.
So with the intraventricular hemorrhage.
Yes, yes.
So yeah, for anti-epileptic drugs, yeah, like you are saying, you mentioned it that it's controversial. There are other centers which don't give others, they give like you give. I wanted just to know which one do you give? Sorry?
Yes. We use. Sorry, I don't hear.
No, I think there's another sound there. After I talk, I could hear something else there.
Okay. Yes.
I could hear feedback. I don't know. Can you hear me now?
Yes, I can hear you now.
Yes.
Okay, for the anti-epileptic drug, we use sometimes the valproic acid or Kepra. I don't remember the name of a molecule, but it's a phenytoin, I think. Phenytoin, yes. Or valproic acid, yes.
Yeah, because also in our center, sometimes we give phenytoin because it's non-sedative anti-seizures, but not on all patients like you mentioned. It's controversial. Yes. We only give to patients who present with seizures. Those who don't present with seizures, we don't give that. Yeah. And also for DVT prophylaxis, other centers are giving. So what they say is, when you do DVT prophylaxis, you give low molecular weight heparin, it will not increase the rate of rebleeding. But if the patient rebleeds, it will be worse.
Okay.
Yeah, if the patient rebleeds while you are giving your low molecular weight heparin, it will be worse. But usually, it doesn't increase the risk of rebleeding.
Oh,
So
okay.
other people prefer to start the DVT prophylaxis after 48 hours. Others are saying after 24 hours. So it depends on the centers. You know, neurosurgery has many schools. And also for EVD prophylaxis, others are only putting EVD when there is hydrocephalus. When there is hydrocephalus, you can get subarachnoid hemorrhage with no intraventricular hemorrhage, no hydrocephalus, and the patient is grade 3 WFNS. Because there's no hydrocephalus, there's no subarachnoid hemorrhage, others prefer to do conservative management.
Yes.
So yeah, thank you so much for your answers and your great presentation.
Yeah, you know, I'd like to make a comment, Fortune. I'm not a neurosurgeon, but I worked in the emergency room, and we occasionally treated subarachnoid hemorrhage. And this is a while ago, 20 or 30 years ago. And we basically didn't do much. They weren't aggressive at all back 20 years ago. That probably Dr. Gabulo doesn't remember before he started. When people came in with subarachnoid bleeds, we just basically put an IV in them and put them in the corner and watched them to see if they could recover. Of course, we do a CAT scan, but there was no neurointervention. There was no thrombolytics. So things have changed, because of the advent of the specialty of neurointerventional radiology, and neurosurgeons are doing coiling and clipping of aneurysms. So the field of subarachnoid hemorrhage treatment has certainly changed.
Yeah.
And it'll probably continue to change too, correct?
Yeah. Yeah. For example, in our center, for example, the research is continuing, and we found that we are going to the endovascular coiling more than surgery.
Okay.
So yeah.
Endovascular. Yeah.
Yeah.
Okay. Well, you know, in the United States, of course, there's a problem of education for the patients, you know, to get to the hospital right away if there's anything going on. But they need to be taken to certain centers that have the equipment. Now, do you guys go through that too, of getting people and having to transfer them to a center that does coiling and endovascular? Do you have to do that too? Do you transfer patients a lot that need that?
Our center is the main hospital in the region. So many people come from another hospital.
It's a trauma center.
Yes. So in the north of Morocco, I think that we are the only one center where we can do the surgery of the clipping and also the coiling of aneurysm. So many people come from elsewhere. And sometimes we come with arteriography, with the CT scan, CT angiography, angiogram, and so on and so forth. So yeah, it's
well, you know, it's the same. Maybe Marco knows about this. Hello, Marco. Maybe Marco knows about this in Italy too. It's a question of education. How you doing, Marco? We're talking about, you know, educating doctors and patients about getting to the hospital if you have stroke symptoms or anything about subarachnoid bleed, headaches. But we're just talking about how sometimes the patient needs to be transferred to a center that does aggressive treatment of neurointervention and coiling and endoscopy. Is the same thing in Italy? You transfer patients to centers and stuff?
Well, of course, in some hospital, we don't have available the endovascular treatment. So when came patients with basilar aneurysm, for example, that is the main aneurysm treated by endovascular, we're forced to move the patients in another hospital, half hours from here, where there is the endovascular treatment available. So is a common thing in Italy.
Okay. Yeah, I think it's in America. It's a question of educating the hospitals that, hey, there's a center here that treats, the acute, subarachnoid bleeds and hemorrhages and blood clots, etc. I know in Latin America, it's a lot of education, not only patients, but hospitals, to let them know that if you have a case that you can be they can be transferred, right, Fortune? It's the same thing probably in Morocco, is letting the hospitals know, hey, we have a stroke center here, or we have endovascular, we can do acute cases. So most of the hospitals in Morocco know that about your hospital?
Yes, here we have the protocol. We have the protocol, therapeutic protocol. So when the patient had the onset headache, he undergoes the CT scan. When the CT scan we found the subarachnoid hemorrhage, automatically the patient is transferred to our.
Oh, okay. You don't have that protocol written, do you? So we could look at it. Do you have it on your laptop, the protocol? Do you have the protocol at all on your laptop? The protocol?
No. I can find it.
Okay, no problem. I just thought you might. So, see, any other comments or questions? And Marco, I know you came late, but we're talking about subarachnoid hemorrhage, the acute treatment. Do you have any comments on the acute treatment of subarachnoid hemorrhage, Marco?
Yeah, I'm a bit late.
Yeah, that's okay. Whatever you have to say about it would be a positive.
Well, actually, I don't have so much thing to add.
Okay.
Just I liked how the dilemma between endovascular and surgical treatment of aneurysm still remain, even if many studies attempt to see what should be the best treatment, but it's not easy at all to define, because there are many factors involved, like the experience of the operator, the clinical presentation of patient, is a young or old patients. In this case, last case, is preferable endovascular treatment. So there is still debate about that.
Okay, Fortune, Marco is a neurosurgeon from Como, Italy. He just got back from the Mayo Clinic, as you can see from his shirt.
Oh yeah, from a Mayo.
Yeah, he's done some time there. But I was saying to Fortune.
Yes, please, I have a question.
Go ahead.
To Marco.
Go ahead.
So Marco, in our department, we don't put all our patients in the ICU. For example, when the patient is a good clinical condition, for example, WFNS grade 1 or 2, we put the patient in the inpatient neurosurgery unit, not in the ICU. But I know that in the literature, the guideline is to put all the patients in the ICU. But according to our condition here, we just have one ICU for the neurosurgery and also another department, only 18 beds, So it's that is because when the patient is grade WFNS 1 or 2, we don't put them in the ICU, but in the inpatient unit. So what's your opinion about this?
Well, I think that when you have a grade 1 of a Fisher grade, you can accept in patient's clinic, but you have always a risk, because the aneurysm can evolve. You can have a new bleeding, so the patient can worse. I think that if in inpatient's clinic you have a monitoring that check the pressure, you know that the worst aspect that can condition a new bleeding is the hypertension. So if you have a monitoring that check the pressure of patients, a good nursing that check the patients every moment to see if there is some worsening, you can put the patients with a Fisher grade 1 in inpatients. If it's over, so you have a bleeding in the ventricle, of course you cannot afford the patients came in inpatients, but moving intensive care unit. I know that in some hospital there is also a logistic problem. If you have just one bed place in intensive care unit, of course you can do more. You cannot create a new bed place in intensive care unit, so you need to face this problem, of course. But usually, if you have a good monitoring of pressure, blood pressure in inpatient, and the patient is a good state, Fisher grade 1, you can put in inpatients.
Okay, thank you.
You're welcome.
Okay, very good. Okay, I'd like to thank you very much, Fortune, for giving a lecture, and you're welcome to give as many as you want.
You're welcome.
And I thank everybody for coming, and I'll send you a recording of this after editing. Okay, so I'd like to say goodbye to everybody. Stick around, guys. We'll chat. Thank you.
Thank you. Goodbye.
Okay. I'm sorry, I gotta stop this here. Stop. Okay, stop. Okay, yeah. Thank you very much, Fortune.
Welcome.
Yeah, all parts of the world. It's education in this field of strokes and subarachnoid. It's education for the patients and the doctors. Doctors like me who used to practice and they, weren't aggressive with bleeds and strokes. We just kind of waited to see whatever recovered, whatever didn't. I mean, that was the way the patients were treated, 20, 30 years ago. You just kind of let them see whatever, but now it seems a lot more encouraging. So anyways, yeah, we're televising, Marco, the conference from Tanzania on Monday and from Pakistan on Thursday, a big ICRAN conference from Pakistan on neurotrauma. So we'll have a lot going on next week.
Oh, great.
Yeah, you'll have a lot to do there. Okay, guys. Well, thank you very much.
Thank you.
Oh, Musindo. Hello, Musindo. You want to say hello to everybody?
Hello, Musindo. Yes, I'm Musindo from Mozambique.
He's from Mozambique. How you doing, Musindo?
Musindo. Yes. I'm Musindo from Mozambique.
Okay,
can
welcome.
You hear me?
Yes, we can.
Thank you.
Yeah, we can.
Hello, Dr. Marco. Happy birthday, Dr. Marco. Today is Dr. Marco's birthday.
Oh, happy birthday. Should we sing happy birthday? Happy birthday to you. Happy birthday to you. Happy birthday, dear Marco. Happy birthday to you.
It's older.
How old are you now?
Yes, how old are you now? Who is your girlfriend?
Okay. That's from the playground. That's an old one, Dr. Kabula.
It's just a song, my dear senior Dr. Marco. It's just a song.
Okay. Very good. Okay, guys. I'll post it on the internet.
Okay, bye-bye.
Thank you. Thank you, everybody.
Thank you very much.
Bye-bye.
Bye.